Hello there, everybody. My name is Ariel Marks. I'm one of the neurologists here at Boston Medical Center, and I'm an assistant professor of neurology at Boston University School of Medicine. And today we're going to talk about EMG tests, which is the best test that we have to test the peripheral nervous system and to try to figure out where someone's symptoms localize. This is a test that we use in conjunction with our history and physical exam. And it really acts as an extension of our physical exam. This is going to be broken down into two videos. The first one will focus on the first half of the test, which is called a nerve conduction study. And the second video will focus on the needle electromyography itself. So again, our EMG is our best tool that we have for localizing in the peripheral nervous system. Our EMG test, if you order an EMG test and the patient comes into our office to have it done, will actually consist of two separate tests. The first is a direct test of the nerves called the nerve conduction study, which again is going to be the focus of this video. And then separately, there's the actual EMG test. It's kind of funny that the whole overall arching test is called an EMG, and you kind of have to use context clues sometimes if you're talking about the whole test versus the needle EMG itself. But again, today we're going to focus on the nerve conduction study. This is a test where we test the nerves directly, and we can separate out what we test between the sensory nerves and the motor nerves. And we can really get a lot of information as to exactly where the sensory and/or motor nerves are being damaged. This is a picture of someone getting a nerve conduction study done. And in this particular picture, they are testing a motor nerve. Here they're stimulating using an electrical stimulator to test the median nerve. The median nerve passes through your arm, down your forearm, straight through the carpal tunnel, and then comes around and innervates this muscle, the abductor pollicis brevis muscle, which abducts your thumb. You see how the patient is lying on a bed, and we place a recording electrode on the muscle that we want to test. In this case, the muscle that we are testing is the APB muscle. And then we record the electrical activity that happens in that muscle after we stimulate with an electrical stimulation. So you press this button, it gives the patient a small shock, kind of like the feeling when you touch a doorknob in the winter. It causes an action potential to travel down the axons of this nerve, and then we can record the muscle as it depolarizes. We can see how fast the signal got there, and we can also see how strong the signal was that was transmitted. So this is, again, the same picture of someone having a nerve conduction study performed specifically of the motor axons that are passing through here. Imagine if you stimulate here, you are stimulating both the sensory and the motor axons, but by placing the recording electrode over the muscle, we are really only recording the motor responses, the motor axons. So we can stimulate at the wrist and record at the APB muscle. And this is what it's going to look like when we stimulate on the computer screen. We're going to stimulate, and then we're going to wait and wait for a couple of milliseconds, about 3.5 milliseconds, and then the electrical potential takes off. And as the muscle contracts, that electrical potential is recorded. Then we're going to do the same thing again, but instead of stimulating here at the wrist, we're going to stimulate up by the elbow. Again, we're going to record at the APB. Now, it's going to take longer to get there because we're traveling all the way down their forearm, but a few milliseconds later, we will see the same depolarization as we record over that muscle. Now, we can calculate a couple of different parameters that tell us about the health and integrity of this motor neuron, of this motor nerve. We can talk about the latency. That means the amount of time that it took before the muscle started to depolarize. We can talk about the amplitude, which is the strength of the signal that tells us how many axons were delivering that information and therefore how much of that muscle depolarized. Then we can measure the patient's forearm between the two spots where we stimulated and divide that distance by the time difference between these two peaks. And by dividing the distance over time, we can measure the velocity across their forearm. If the latency is long, if it took a long time for the message to get down that nerve, or if the velocity is slow, that tells us that there is a myelination problem, a problem with demyelination, because that signal took too long to get there. Conversely, if the amplitude is low, then that tells us that it's not a problem with the conduction through the myelin, but rather it's a problem of having too few axons to transmit the signal. If you have nerve damage that causes degeneration of the axons themselves, and only half of the axons are still alive and working, then the signal is going to be only half the size. So this is really where we can break down a nerve damage in our peripheral nervous system into demyelinating processes versus axonal processes. This is something that you can't do on your physical exam and that you need a nerve conduction study in order to differentiate. Now we can test the sensory neurons. And the way that we do that is by changing where we're recording from. If you remember, the motor testing a part of our nerve conduction study, we had recorded over the muscle belly. Instead, what we do is we record on the finger. The fingers have little, if no, muscle inside of them. If you think about it, most of the finger is just fat pads and tendons and bones, and most of the muscles that control the fingers really live all the way out here in the forearm. So by placing the recording electrodes on the patient's finger, we can just isolate the sensory nerves. This is a sensory nerve, and I'm going to take a minute to talk about the architecture on a cellular level of the sensory neuron. This is a sensory neuron. It has this special architecture, this pseudo-unipolar structure where it has one axon that comes out of the cell body and then breaks into two. It's not bipolar. Bipolar would have one axon on one end and one axon on the other. We call it a pseudo-unipolar. So it can travel all the way to the nerve endings in the bottom of your feet, for example, and that neuron travels all the way up your leg to your lower back, where we reach the dorsal root ganglion, where the cell body of the sensory neuron lives. This is called the dorsal root ganglion. I want to show you a picture here of the spine so you can get a sense of where the dorsal root ganglion is. It's right over here, dorsal root ganglion. You can see that the peripheral nerve comes in, and just before it enters the spinal canal is where the cell body is. So that by the time you get into the spinal canal, you've already passed the dorsal root ganglion. And this is the ramus that carries the sensory signals up to the dorsal column. Imagine if you had a disc pushing on the nerve roots. It is going to push on the nerve roots proximal to the dorsal root ganglion, above the dorsal root ganglion. And that's going to make a big difference in our nerve conduction study, as you'll see in a minute. Then that sensory neuron continues to travel up the dorsal column until it gets to the nucleus gracilis and cuneatus. One cell that goes from the tip of your toe to the base of your brain, and the cell body lives right in the middle at the spinal level that it enters. Now we're going to test those sensory neurons. We're going to stimulate here at the wrist and record at the finger. Imagine if we damage the peripheral nerve here, below the dorsal root ganglion, or on this picture, distal to the dorsal root ganglion all the way out here. What's going to happen? This axon is no longer receiving all the proteins and microtubules and vesicles that it needs, that are created here in the cell body, and therefore this is going to degenerate. If we try to record here and stimulate at the finger, as we do, that signal is going to be diminished because we've lost some of these axons. And so you see how this peak is very small. We get a very small peak because a lot of these axons are lost. However, what if we have a lesion here? Imagine you have a disc that's pushing on this axon proximal to the dorsal root ganglion. This axon is going to degenerate. However, this axon is still connected to the cell body, and therefore it will not degenerate. And if we record here distally, as we do in the wrist, it's going to look fine. The response is going to be a nice normal response because the damage is not down here. This axon stays healthy. It's this proximal axon that degenerates. The patient will feel numb when they have disc disease causing a nerve root disorder. But when we test their sensory neurons in the nerve conduction study, it will be normal. And this is one of the great divides in the peripheral nervous system. When we test their nerves in the nerve conduction study, the sensory neurons will not be affected if the damage is proximal to the dorsal root ganglion. It will only cause a loss of the sensory response if the damage is distal to the dorsal root ganglion. So, just to summarize, we just spoke about the nerve conduction study, including the sensory and motor portions. And in the next video, we will talk about the needle electromyography.